Welcome back to the Deep Dive. Today, we're going to do things a little differently. We are turning this into a high-intensity study session.
Okay, I like it.
So if you're listening, I want you to picture this. You're a final-year anesthesiology resident. The coffee's gone cold, your textbooks are open, and your MD exams are right around the corner.
That's a stressful visualization, but a very, very accurate one for many people.
It has to be.
Okay.
Because the topic we are diving into today is, well, it's arguably the examiner's favorite weapon.
Mm-hmm.
It touches on every single domain. We're talking physiology, pharmacology, physics, and of course, high-stakes airway management. We are talking about anesthesia for the obese patient.
It is the ultimate multi-system Viva question. And, it's a favorite because it really exposes whether a candidate truly understands the underlying physiology or if they've just memorized a list of facts.
Right.
Obesity isn't just about a number on the scale. It's a chronic multi-system inflammatory disease that completely rewires how the body works.
Exactly. And looking at our sources today, we've got Muller, Harrison's various clinical guidelines. It's clear we have to go way beyond the basics. So we're going to structure this in an exam-ready format.
Sounds good.
We'll start with the definitions and classifications, work our way through all the body systems, and then tackle that special topic that always trips people up, liposuction.
Let's do it.
Okay, section 1, the introduction. Why does this topic matter so much right now for the anesthesiologist?
Well, it matters because the patient population has fundamentally changed. Obesity is no longer a special case you see once in a while.
It's the daily reality in the operating theater.
It's the daily reality. Anesthesiologists are, more and more, the primary physicians managing the entire perioperative risk profile of these complex patients. And that risk, it's not just, they might have a difficult airway.
No, it's everything.
It's everything. It's the fact that their physiological reserves across every single organ system are diminished. The margin for error is. It's just razor thin.
Okay, so let's start with the absolute basics. The stuff every candidate has to know, cold, classification.
Right. You have to start your exam answer with the definition. Obesity is a disorder of energy regulation that involves an excess of body fat. Simple as that.
And we quantify that with BMI.
We quantify it with the body mass index, or BMI. That's weight in kilograms divided by height in meters squared. You have to know the formula.
And the numbers. Walk us through the classes.
Sure. So normal is considered up to 24.9. Overweight kicks in at 25 and goes to 29.9. Then you hit obesity class 1, which is 30 to 34.9. Class 2 is 35 to 39.9. And then class 3, which is what we used to call morbid obesity, is a BMI of 40 or greater.
And it doesn't stop there, does it?
No. Then you have the category of super obesity, which is a BMI greater than 50. And even super obese, which is over 60.
But just rattling off BMI numbers in the exam?
Yeah.
That's not going to impress anyone.
Not at all. That's the pass-fail answer. To get the gold medal, you have to immediately pivot to fat distribution.
This is the apple versus pear shape.
Exactly. The android versus gynoid obesity. This is so critical because, as we said, BMI is a blunt instrument. It doesn't tell you where the fat is.
And for us as anesthetists, location is everything.
Everything. The central or android obesity, the apple shape, that's the really dangerous one. This is visceral fat packed around the organs.
And it's metabolically active, right?
Highly active. It's like a little factory just churning out inflammatory cytokines, driving insulin resistance, and creating a massive cardiovascular risk profile.
Compared to the pear shape.
Right, the peripheral or gynoid obesity. That's where the fat is mostly subcutaneous, on the hips and thighs. Mechanically, it's heavy, sure, but metabolically, it's much, much quieter.
So a simple measurement like waist circumference can tell you a lot.
A huge amount. A waist circumference greater than 102 centimeters in men or 88 centimeters in women is a massive red flag. That tells you there's significant visceral fat, which implies
Metabolic syndrome.
the metabolic syndrome, a critical Viva topic. You need 3 of the 5 criteria: central obesity, high triglycerides, low HDL, hypertension, and high fasting glucose. That cluster is what really drives the risk.
Okay, let's move on to the systems. Section 3, the respiratory system. This is always the biggest section in the exam, isn't it?
It is, and for very good reason. The most fundamental change you see is a reduction in lung volumes.
Restrictive pattern.
It's essentially an acquired restrictive lung disease, all that excess weight on the chest wall plus the abdominal panniculus. It's like having a giant sandbag on the patient's chest and belly.
And that pushes the diaphragm up.
It splints the diaphragm. It can't move down. It absolutely crushes the functional residual capacity, the FRC.
And the FRC is our oxygen reserve during apnea.
It is our entire safety buffer. In a healthy person, it's about 30 milliliters per kilogram. In an obese patient, that can be slashed in half, especially just by laying them supine for induction.
And this is where we get into that real high-yield exam concept, the relationship between FRC and closing capacity.
Yes. If you can explain this clearly, you will impress the examiner. This is the difference between a pass and a distinction.
So closing capacity is the lung volume, where the small terminal airways start to collapse.
Precisely. In a healthy person, your FRC is well above your closing capacity, so even when you breathe all the way out, your small airways stay propped open.
But in the obese patient, that's not what happens.
Not at all. Because that FRC is pushed down so dramatically, it actually falls below the closing capacity.
So what does that mean clinically?
It means that even during normal, quiet, tidal breathing, while they're awake, just sitting there, their small airways are collapsing at the end of every single breath.
Wow. So they have VQ, mismatch, and shunting before we've even given a single drug.
You've got it. They are starting from a baseline of atelectasis, and that directly explains the rapid desaturation we see after induction.
But it's only part of the story, right?
It's part of it. It's a classic double whammy. On one hand, you have a much smaller fuel tank. That's the reduced FRC.
And on the other?
A much bigger engine. Adipose tissue is metabolically active, so their baseline oxygen consumption and CO2 production are significantly higher.
Small thing, big engine.
Exactly. So when you induce anesthesia and they become apneic, you don't have minutes of safety. You have seconds.
We absolutely have to talk about sleep-disordered breathing as well.
It's mandatory. You have to bring it up. Most people know about obstructive sleep apnea, or OSA. That's the structural collapse of the pharynx during sleep.
But the key is to distinguish it from OHS.
Yes, from obesity hyperventilation syndrome, which used to be called Pickwickian syndrome. This is a different beast entirely.
How do you differentiate them in an exam answer?
OHS is defined by a triad. First, you have obesity, obviously. Second, you have sleep-disordered breathing. But the crucial third part is awake, daytime hypercapnia.
So their PECO2 is high even when they're awake.
Correct. Their arterial CO2 is greater than 45 millimeters of mercury while they're sitting there talking to you. This tells you they have a blunted central respiratory drive. Their brain has just gotten used to high CO2 levels.
Which means they are incredibly sensitive
To opioids and sedatives. They have almost no respiratory reserve. A small dose of morphine that would be fine for anyone else could cause them to stop breathing.
Okay, that's a huge point. Let's move to section 4. The cardiovascular system. I think there's a common misconception that obese patients are just full of blood.
It's a dangerous half-truth. Their total blood volume is absolutely increased because you need to perfuse all that extra adipose tissue. But, and this is the key point for dosing and fluid management, their blood volume per kilogram of body weight is actually lower than in a lean patient.
Can you give us some numbers on that?
Sure. A lean patient is around 70 milliliters per kilogram. A morbidly obese patient might be as low as 50 milliliters per kilogram.
So if you calculate their allowable blood loss or fluid replacement based on 70 milliliters per kilogram using their actual total body weight,
you will massively overload them. You'll put them into heart failure. It's a classic trap.
and what's happening to the heart itself?
Well, to handle all that extra tissue and blood volume, the cardiac output has to increase. We estimate it goes up by about 20 to 30 milliliters per minute for every single kilogram of excess fat.
And that's mostly stroke volume driven initially?
Initially, yes. But over time, that chronic volume overload leads to eccentric left ventricular hypertrophy. The heart gets bigger and dilated.
And then you have the hypertension that's almost always present.
Right. And that pressure overload leads to concentric hypertrophy, where the heart wall gets thick and stiff. This is what causes diastolic dysfunction. The heart can't relax properly to fill with blood.
And eventually that can progress to outright heart failure.
Yes. You can even get something called obesity cardiomyopathy, which is heart failure from direct fatty infiltration of the heart muscle itself, independent of blood pressure or coronary artery disease. It's a direct toxic effect of the fat.
Let's touch on the GI system, section 5. For us, the rule is simple. Treat them as a full stomach, right?
Always, 100% of the time, no exceptions. The combination of increased intra-abdominal pressure from the weight of the abdomen plus a very high prevalence of hiatus hernia and GERD.
It means the aspiration risk is high.
The risk is always considered high. Now, some studies in Miller show that in fasted obese patients, their gastric volume and pH might not be that different from lean patients.
But that's academic, really.
It is, because the consequences of aspiration in a patient with a known difficult airway and almost no oxygen reserve are so catastrophic, you simply cannot take the risk. They get a rapid sequence induction.
Okay. Section 6, endocrine and metabolic changes. We sort of touched on this with the apple shape.
We did. You have to mention the high prevalence of insulin resistance and overt type 2 diabetes.
In the dyslipidemia.
And the dyslipidemia. It all comes back to that visceral fat acting as an endocrine organ, creating a pro-inflammatory, pro-thrombotic state.
Which brings us to Section 7, pharmacology, the dosing dilemma. This is the math section of the exam.
And it's where so many candidates fall down. You absolutely cannot just use one weight, total body weight, for all your drugs. You have to think about the pharmacokinetics.
So let's break it down. Lipophilic drugs versus hydrophilic drugs. Where do we start?
You start with the physiology of fat. Adipose tissue has very poor blood flow. It only gets about 2 to 5% of the cardiac output.
Okay, so it's not well perfused.
Not at all. So when you give an induction bolus of a highly lipophilic drug like propofol, it doesn't have time to distribute into that big fat compartment. It stays in the central vessel-rich group, the brain, the heart.
So for a propofol induction dose,
You must dose it on lean body weight, LBW. If you calculate the dose based on a patient's total body weight of, say, 150 kilos, you will deliver a massive overdose to their brain and heart.
and cause profound hypotension.
Profound, dangerous hypotension. Now, for a maintenance infusion, you might consider using a different weight because over time, the drug will start to seep into the fat. But for the initial bolus, it's lean body weight.
Okay, what about the hydrophilic drugs, like our neuromuscular blockers?
These drugs, like rocuronium or vecuronium, stay in the plasma and extracellular fluid. They don't distribute into fat at all.
So again, you'd use lean body weight.
You dose them on lean body weight. If you give a 150-kilo patient rocuronium based on their total weight, you're giving them 3 or 4 times the necessary dose. They'll be paralyzed for hours.
But there is the famous exception, the one they'd love to ask about in the Viva.
Ah, yes. The classic trap.
Succinylcholine.
Succinylcholine. You must state very clearly that you dose succinylcholine on total body weight.
And the examiner will immediately ask you why.
And the answer is because the enzyme that breaks it down, plasmacholinesterase, its activity is directly proportional to body mass. It increases with body weight.
So you need a bigger dose to overcome the enzyme and get to the neuromuscular junction.
Exactly. You need that larger dose to ensure you get profound, rapid paralysis for intubation. Underdosing succinylcholine in a predicted difficult airway is a recipe for disaster.
Okay, that's crystal clear. Section 8, preoperative evaluation. We're in the pre-op clinic. What are the key things we're looking for?
Well, beyond all the standard history, you're really focusing on 2 main areas: the airway and their cardiopulmonary reserve.
For the airway, what are the red flags?
A thick neck. Neck circumference is actually a better predictor than Mallampati score. A neck size greater than 43 centimeters, or about 17 inches, is a very strong predictor of a difficult intubation. You're also looking for limited neck mobility due to those big fat pads on the back of the neck.
And we have to screen them for OSA.
Absolutely. You use a validated tool like the Stuppy-Bang questionnaire.
Snoring, tiredness, observed apnea, high blood pressure.
BMI over 35, age over 50, neck circumference, and male gender. A score of 5 or more is considered high risk for severe OSA. And if they're high risk, you manage them as if they have it, even if they don't have a formal sleep study.
What about their cardiac workup? They probably can't run on a treadmill.
Almost never. Their joints, their knees, their hips just won't allow it. So assessing their functional capacity is really difficult. You have to have a very low threshold to order further tests, like a dobutamine stress echo, to properly assess their LV function and look for any signs of pulmonary hypertension.
Okay, Section 9, airway management, the moment of truth.
It is, and success here is all about preparation. The single most important maneuver is positioning. You must use the ramped position.
Also known as HELP head elevated laryngoscopy position.
That's the one. You're stacking blankets or using a special pillow to elevate their head, shoulders, and upper back until their sternal notch is level with their external auditory meatus.
The ear hole.
The ear hole. This does two critical things. It aligns the airway axis, but more importantly, it uses gravity to pull all that redundant breast tissue and the abdominal panniculus down and away from the chest and neck.
It makes a huge difference. What about pre-oxygenation?
Crucial. You need to do it with them in a head-up or reverse Trendelenburg position. This helps increase that FRC. And you should strongly consider applying CPAP or PEEP, maybe 10 centimeters of water, during pre-oxygenation.
Why is that?
Because remember, they are atelectatic at baseline. You need that positive pressure to recruit those collapsed alveoli before you put them to sleep and they become apneic. You're trying to fill that tiny oxygen tank as much as you possibly can.
Section 10. Anesthetic technique.
Yeah.
General versus regional. What's the thinking here?
Well, regional anesthesia is very attractive on paper. You avoid manipulating the airway, you avoid opioids, you get great post-op pain relief. But it can be incredibly technically difficult. The landmarks are buried under layers of tissue. Your standard needles might not even be long enough to reach the target space.
So ultrasound guidance becomes essential.
It becomes almost mandatory, I would say, but even with ultrasound, it can be a challenge. So often, because of the type or duration of the surgery, general anesthesia is simply unavoidable.
Okay, so we've decided on a GA, Section 11, intraoperative management. We've induced, the tube is in. How do we ventilate these patients?
You use a lung protective ventilation strategy. This is non-negotiable. The tidal volume must be set at 6 to 8 milliliters per kilogram of their predicted body weight.
Not their actual weight.
Never their actual weight. Their lungs are not 150 kilos in size. They're the size determined by their height. If you use their actual weight, you will cause massive barotrauma and volutrauma.
And what about PEEP?
PEEP is mandatory. You need a higher level of PEEP than in a non-obese patient, often 10 to 12 centimeters of water, sometimes more. You need that pressure to stent open those airways that are trying to collapse.
And you'd use recruitment maneuvers if needed.
Yes, if their saturation starts to drop intraoperatively, a recruitment maneuver, a sustained high-pressure breath, can help reopen those collapsed lung units.
Let's talk about the end of the case. Section 12, post-op and extubation.
The golden rule here is do not perform a deep extubation. Absolutely not. They must be fully, completely awake.
And positioned correctly.
Positioned in a semi-sitting 45-degree angle at least. You want them to be able to take a deep breath. And you need to ensure they are fully reversed from their neuromuscular blockade.
Sugabex is probably the drug of choice here.
It is the gold standard in this population. It's more reliable and complete than neostigmine. And remember, for reversing a deep block, Sugammadex should be dosed on total body weight.
And post-op pain control.
Multimodal analgesia is the rule. You want to be opioid sparing. Use everything in your toolbox. Paracetamol, NSAIDs if appropriate, local anesthetic infiltration by the surgeon, regional blocks, ketamine, dexmedetomidine, anything to reduce the opioid requirement.
Because of that sensitivity to respiratory depression.
Exactly. Especially if they have underlying OSA or OHS.
What if they end up in the ICU? Section 13.
Well, if they're in the ICU, weaning from the ventilator is often very difficult. They have a high work of breathing. Early mobilization and aggressive DVT prophylaxis are also critical because their risk of getting a blood clot, a DVT, or a PE is massive.
Let's pivot to a couple of specific surgical scenarios. Section 14, laparoscopic surgery. You've called this the perfect storm.
It truly is. You start with a patient who already has a heavy chest wall and a compromised FRC. Then, the surgeon insufflates the abdomen with CO2 gas for the pneumoperitoneum.
Which pushes the diaphragm further up into the chest.
Pushes it way up. And then, to top it all off, for many procedures, they ask for steep Trendelenburg position, head down.
At that point, the FRC has essentially vanished.
It's gone. Their peak airway pressures will skyrocket. It can become almost impossible to ventilate them. You have to be in constant communication with the surgeon. You might have to say, you need to lower the insufflation pressure, or we need to level the table out for a minute so I can ventilate.
Okay, what about bariatric surgery? Section 15.
Well, these are usually done in specialized centers of excellence, but all the principles we've discussed still apply, just amplified. The main difference is in the post-operative phase. You have to be incredibly careful to protect the new surgical joint, the anastomosis.
So no blind NG tubes.
Absolutely no blind NG tubes. You could perforate the staple line, And aggressive nausea and vomiting control is paramount because retching could put too much strain on that fresh anastomosis.
Sections 16 and 17 cover complications and risk reduction, which I think we've woven throughout the discussion. But I want to spend some time on a very specific high-yield topic from the outline, liposuction.
Ah, yes. Sections 18 through 23. This is a topic that's often dismissed as just cosmetic, but from a physiological standpoint, large volume liposuction can be incredibly complex and dangerous.
Let's start from the beginning, Section 19. What exactly is the tumescent technique?
Right. So liposuction isn't just about sticking a cannula in and vacuuming out fat. Before that happens, the surgeon first infiltrates the subcutaneous fat with a massive volume of a special fluid. This is the tumescent solution, most famously Klein's solution.
And what's in that solution?
It's a crystalloid base, like normal saline or Ringer's. Mixed into that is a very dilute local anesthetic, usually lidocaine. Then you have adrenaline or epinephrine, and often some bicarbonate to reduce the stinging on injection.
And what's the purpose of all that?
It's multifunctional. The huge volume of fluid makes the fatty tissue firm and swollen or tumescent, which makes it easier for the cannula to pass through.
Okay.
The adrenaline causes intense local vasoconstriction, which dramatically reduces bleeding. And the lidocaine, of course, provides local anesthesia.
You said the volumes are huge. How huge are we talking?
We can be talking about many liters of this solution being injected under the skin. And this leads us directly to Section 20, the physiological effects. The number one risk is fluid overload.
Because all that saline or Ringer's eventually gets absorbed systemically.
Exactly. And this is a classic exam trap. The anastomotist is charting fluids, they see the urine output, and they start running their standard IV maintenance fluids, completely ignoring the 5 liters the surgeon has already pumped into the patient.
And the patient goes into pulmonary edema.
They can, absolutely. You have to count the tumescent fluid as part of your total fluid input. The other big risk is hypothermia. You're injecting liters and liters of room temperature fluid under the skin. It acts as a massive internal heat sink. You must use aggressive active warming.
And what about anesthetic techniques for these cases?
For small volume lipo, say less than a liter, it can be done just with the tumescent local and some sedation. But for what we call mega liposuction, which is more than 5 liters of aspirate, general anesthesia is much safer. You need to secure the airway and be able to aggressively manage the physiology.
Okay, let's talk about the really scary part. Section 22, complications. The biggest specific fear is AST, right?
Yeah.
Local anesthetic systemic toxicity.
It is. This is a huge concern.
But hold on, you said the lidocaine is very dilute?
It is dilute, but the total dose given can be astronomical. In our normal anesthetic practice, we limit lidocaine with adrenaline to maybe 7 milligrams per kilogram. In tumescent liposuction, doses of 35 milligram kilogram up to even 55 milligram kilogram are considered standard and are used routinely.
55 milligrams per kilogram. Wait, that sounds completely lethal.
It would be if you gave it intravenously. The whole concept relies on the fact that fat is poorly vascular, and the adrenaline causes such intense vasoconstriction that the absorption of the lidocaine is incredibly slow and prolonged.
So the peak plasma level is delayed.
Very delayed. The peak serum level of lidocaine might not even occur for 12 to 14 hours after the infiltration is finished.
So the patient could develop seizures at home long after they've been discharged.
That is the absolute danger. They could be at home when they start getting the classic signs: perioral numbness, tinnitus, agitation, and then seizures. That's why post-op monitoring for these patients is so critical.
What about fat embolism syndrome?
Also a very real risk. The mechanical disruption of the fat tissue can tear small blood vessels, allowing fat globules to enter the venous circulation and travel to the lungs. It classically presents with hypoxia, confusion, and a petechial rash.
Okay, so a lot to watch for. If you were making a comparison table for an exam, obese versus non-obese patient, what are the headlines?
Okay, quick headlines. 1. Airway. Predictably difficult versus usually straightforward. 2. EPRC, markedly reduced versus normal. 3. Aspiration risks, assumed full stomach versus fasted. And 4. Drug dosing, complex calculations with LBW versus PBW versus standard weight-based dosing.
And what about comparing liposuction versus bariatric surgery?
Okay. 1. The goal. Bariatric surgery is for metabolic disease and major weight loss. Liposuction is for body contouring only. It is not a weight loss procedure. 2. The fluid shift. Lipo has a massive fluid overload risk from the infiltration. Bariatric surgery has a risk of dehydration or a leak. And 3, the anesthetic. Lipo involves that huge local anesthetic drug load, whereas bariatric surgery does not.
Perfect. Section 25, common exam questions and Viva traps. Let's do a rapid fire round. What are examiners looking for?
Trap number 1, the succinylcholine dose. They'll give you a scenario. Your patient weighs 160 kilograms. How much succinylmethonium do you give? If you say 100 milligrams, you failed.
You have to say dosed on total body weight, so likely 1.5 milligrams per kilogram, which would be around 240 milligrams.
Exactly. Trap 2, fluid management in liposuction. Forgetting to count the surgeon's tumescent fluid as an input.
Trap 3, pre-oxygenation. Just saying I'll pre-oxygenate for 3 minutes is not enough. You have to mention the ramp position, head-up tilt, and the use of CPAP or PEEP.
Yes. And trap 4, extubation. Saying you'll extubate an OHS patient deep or flat, it's a critical error. They must be wide awake and sitting up.
Okay, let's wrap it all up. Section 27, summary and conclusion. Give us the final high-yield take-home points for the exam.
Okay, here we go. Your 10 golden rules. 1, obesity is a multi-system inflammatory disease, not just a weight issue.
2, fat distribution, the apple versus the pear, matters more than the BMI number.
3, FRC is reduced, often below closing capacity. Expect rapid desaturation on induction.
4, pre-oxygenate in the ramp PEEP position, head up, with PEEP.
5, dose lipophilic drugs like propofol and hyperphilic drugs like rocuronium on lean body weight.
6, dose succinylcholine on total body weight, no why.
7, ventilate with 6 to 8 milliliters per kilogram of predicted body weight and use PEEP.
8, assume they have OSA and use an opioid-sparing multimodal analgesia technique.
9, for liposuction, watch for fluid overload from the tumescent solution and for delayed local anesthetic toxicity.
And 10.
And 10, treat the physiology, not just the number on the scale.
That is an absolutely fantastic and comprehensive run-through.
It's a huge topic, but if you can stick to those first principles, the physiology and the pharmacology, you won't just pass the exam, you'll sound like you're ready to be a consultant.
Professor, thank you so much for the masterclass. And to our listeners, good luck with the books. Go and review those dosing scalars just one more time.
And please get some sleep. You'll need it. We'll see you on the next deep dive.